Well, good afternoon, everyone, and welcome to the Prenatal-to-3 Policy Impact Center's next series of our workshops. Today, we're going to be exploring how states are using or leveraging Medicaid to fund various strategies in the Prenatal-to-3 State Policy Roadmap. I'm Cynthia Osborne, and I have the privilege of directing the Prenatal-to-3 Policy Impact Center here at the University of Texas at Austin and the LBJ School of Public Affairs. And today I am joined by an amazing group of specialists who know more about Medicaid than probably anyone on the planet, and also folks who have been working with states on how they can effectively leverage Medicaid to help them to fund prevention and early intervention services. I'm going to take just a minute to talk about the state policy roadmap that we're referring to. I know that many of you were able to join us October 7th when we launched the second annual state policy roadmap. But I'm going to go over it just briefly and then introduce our panelists, which I know are who you've come to view today. Let's see if I can get my screen to work here. So the state policy roadmap is a resource for states to use that can help them as they're trying to develop and implement what research says are the most effective policies that can empower parents and ensure that children get off to a healthy start and thrive. And if you haven't had an opportunity to view your state's policy roadmap, I invite you to visit our website at pn3policy.org/roadmap. And you can either see the US roadmap or your individual states, and to make sure that you are able to visit these individual profiles on each of our 5 effective policies and 6 effective strategies that, again, research says help to ensure that children get off to a healthy start and thrive. And the whole idea was that we wanted to be guided by the science of the developing child that tells us that children need to be born and raised in safe and stable and nurturing and warm environments in which their parents have access to the resources and the skills that they need to be the parents that they strive to be. And that when children are not with their families, that they are in nurturing and safe environments as well. So given that science, we turn to the most rigorous evidence available to date to identify what it is that helps to create those conditions. And we identified 5 policies and 6 strategies that research says really work. And the 5 policies are broad economic and family supports. And one of them is expanding the income eligibility threshold for health insurance, namely that states could expand Medicaid. We also want to make sure that we reduce the administrative burden that families face so that they can have access to the services that they're eligible for. We know that a paid family leave program of at least 6 weeks leads to positive outcomes for both the mother and the child. We know that a state minimum wage that's at least $10 an hour also leads to better birth outcomes in addition to better, more household resources and lower rates of poverty. And same with an earned income tax credit that's at least 10% of the federal credit and refundable. And so, although Medicaid is certainly on the roadmap, that's not what we're going to be talking about specifically today in terms of its access to health insurance for adults. What we're actually going to be talking about is how states are using Medicaid to fund more of these targeted interventions. So 4 out of our 6 effective strategies are being funded through Medicaid in various states across the country. And so I'm not going to talk today about how important childcare subsidies are, but I think hopefully we're all paying attention to this in the larger conversation, and we might be seeing incredible contributions from the federal government to support the childcare market. So I'm not going to talk about childcare or early Head Start, but all 4 of the other, or 4 out of the other 6 strategies are able to be funded through Medicaid. So one is these comprehensive screen and connection programs that meet families where they are. They're voluntary but universal, and they conduct comprehensive screens and identify the specific needs that families have and connect them to those services. And several states are using Medicaid to fund the program, particularly Family Connects. And you can see that in lots of states that are even offering Family Connect, still the percentage that are being offered is relatively low. And so when states can leverage Medicaid to help to provide these programs, they can actually increase the percentage of families that are served. Second, we know that 9 states are using Medicaid to offer an enhanced reimbursement rate for group prenatal care services. And these are effective services at supporting parents and birthing people during the pregnancy process. And it leads to greater health outcomes for the mom, especially socio-emotional outcomes. And we're going to hear from states that have learned how to leverage Medicaid in order to fund these services. And right now you can see across states that there's a wide range in the percentage of mothers who are eligible or able to access, in this case, the program model centering pregnancy, which is the program model of group prenatal care that's been most rigorously evaluated. Fourth, we're going to be looking at evidence-based home visiting programs, and there are 23 states that are currently using Medicaid to fund portions of their home visiting programs. Ohio is currently in the process of updating its state plan in order to use the case management element of Medicaid in order to fund its home visiting programs as well. And there's a wide range of percentage of families that are served through home visiting services. And we know that states can fund more programs if they're using Medicaid. And finally, early intervention services. The experts in early intervention say that by maximizing states' use of Medicaid, that's really how you can expand the number of services available to children. And the percentage of children who are served by early intervention services, or Part C, ranges from 2% to over 20% across our states. And that has largely to do with how they can fund the services that families need. So again, the whole purpose of today is to have a conversation about how states are leveraging Medicaid in order to support families in these earliest years. And we're going to begin by hearing from Kay Johnson, who really is the national expert on Medicaid and so many other things that have to do with strengthening families. She's the president of the Johnson Consulting Group. And we're also so glad to be joined by Matt Sallow, who is the executive director of the National Association of Medicaid Directors, who obviously these are folks who have a huge stake in how states can use Medicaid for this and what some of the challenges are in doing that. And we'll also hear from Elizabeth Burek from Georgetown University, the Center for Children and Families, who is, again, a national expert in understanding how states are using Medicaid and how they more effectively can. Following these three, then we're going to be joined by folks who are really experts at specific strategies. So Kate Russell, who is the Medicaid program manager in New York, is going to talk about their pilot initiative that they've been doing to use Medicaid in the first 1,000 days of a child's life to try to improve their outcomes and opportunities. And Dr. Melody Baker is going to share with us her understanding of those programs, and she's been evaluating them in New York for the state. So we'll hear from both of those, particularly when it comes to looking at home visiting programs and comprehensive programs. We'll also be joined by Maureen Greer, who is the national expert on Part C and early intervention services. I'm the executive director of the IDEA Infant and Toddler Coordinators Association, who will share with us how states are using Medicaid to fund early intervention or Part C services. And we'll hear from Kara Hinckley, who works with the Centering Health Institute, and will share with us how states are using Medicaid to offer enhanced reimbursement rates for group prenatal care services. So thank you again for joining us this afternoon, and I look forward to a really exciting set of panelists. And after they are finished, I will come back on and we'll talk about how you can go and have more in-depth conversations based on the area that you're most interested in. So again, thank you for joining us, and I'd like to introduce Kay.
Thank you so much. I'm very delighted to be here. I'm really happy to be able to share with you today a little bit more about using Medicaid financing prenatal to 3 to improve lifelong health and well-being. Let's see what we've got. I like to approach this by talking about the 3 E's for understanding Medicaid. This is a way that I've been understanding Medicaid and teaching others to understand it for almost 40 years. And it's really, you have to think about whether Medicaid can finance something or not. Is it an eligible service? Is it for an eligible and enrolled child? And is it delivered by an eligible and enrolled provider? So let's start by talking a little bit about the eligible children. I think I've been saying a lot that Medicaid and the Children's Health Insurance Program, known as CHIP, really matter for child health and equity, and that we've got to make these programs perform well in order to ensure equity. We can't do it without them. Over half of all babies, 2.1 million infants, are enrolled in the Medicaid program, and that includes 6 in 10 Black, Indigenous, and Latinx babies. We also have 4 in 10 children with special health care needs, and over half of the children of color of all ages. The other reason to think about this population is that when we think about the proportion of children who use services, it's around 90% of children who get a preventive health visit in a year in these early years. And among the toddlers, I'm going to show you more about that data. There are 4.6 million 1- and 2-year-olds, for example, enrolled. 80% of them are seen in a health setting, as compared to roughly half are in childcare more than 10 hours a week. On an average, we're down around 5% nationally for Part C and special education for young children, and then home visiting, a relatively small percentage. So thinking about eligible providers, there's sort of a usual suspects aspect to this. The providers have to enroll with the state and they have to be qualified. I put some typical examples there: physicians, nurses, dentists, an array of mental health workers, and the kind of facilities like hospitals, clinics, and freestanding birth centers. But there are other people in the care team who really might be community health workers or doulas or others. And states have an option to use something called a state plan amendment, that they choose to reimburse preventive services recommended by a physician or other licensed practitioner. That used to say supervised by. This was changed under the Affordable Care Act. So states can use this to fund the work of community health workers, lactation consultants, and others. Eligible services is obviously the most complicated aspect of this. The important thing to know is that it really is based on the Early Periodic Screening, Diagnostic, and Treatment Program, known as EPSDT. EPSDT is the child health benefit package in Medicaid, and virtually anything you do in Medicaid for a child is under the authority or the structure of EPSDT, and it includes comprehensive well-child visits, physical, developmental, hearing, vision, dental, and mental health screening and services, and coverage for an array of services and treatments for children when medically necessary. So just on the left side here, some examples of services that may not be covered in your state for adults, but are required to be covered for children, such as case management or mental health, or I'm sure Maureen will talk more about the occupational, physical, and speech therapies. There are other ways that states are doing this that aren't listed specifically in categories, but they're examples of ways that states have been promoting health and development, such as encouraging use of all the recommended screens with objective tools. So general development, social, emotional, maternal depression, and social determinative health. Having done developmental services and supports provided, having parent-child dyadic mental health promotion and treatment, and home visiting, which we're going to talk more about. I want to use this map as an example of how well states are performing. So this is, what percentage of the infants, what percentage of the toddlers, the 1 and 2 year olds, had at least one EPSDT well child visit in the year. Now, for that age group, we would expect 2 in each year. And what you can see is in the grays, those are above the 80% performance goal for the country. And in the corals, those are below the national goal. And basically, the lighter the color, the fewer children who are getting it. So what we can see is that there are wide areas of the country where children aren't even getting one in a year when they should have had 2. So we have work to do in getting the right care to the right child at the right time. In my work with Charlie Bruner over recent years, we have, from a bottom up, talking to practices, and from a top down, talking to state agencies, put forth a design for something we call a high performing medical home for young children in Medicaid. And we just say we need to do more on well child visits in the primary care setting, have it holistic and team-based, having adhered to guidelines, having that array of screening, supporting parents, and having it being strengths-based, family-centered, and 2-generation. In care coordination and case management, routine coordination for all in that medical home, but more intensive care coordination with family-driven approaches in that setting as well. And then in terms of other services, some things we're now wanting to co-locate in primary care, evidence-based models such as Healthy Steps or Dulce, or having integrated behavioral health in primary care, and then having effective referrals and linkage to things like home visiting or early intervention or mental health. So why, you say, do we need to start talking about this fancy thing called a high-performing medical home for young children? Well, we need something that's more team-based, preventive, and family-driven for these youngest children. The Academy Pediatrics policies and guidelines are now calling on providers to do more with those safe, stable, and nurturing early relationships, responding to social determinants, and addressing the impact of racism. States could get more value through this kind of enhanced primary care. And we know incentives from doing this with adults in patient-centered medical homes that we can do this. We have levers. Let me just talk for a moment about some state progress. Some of the roads taken, and I've kind of keyed off of the roadmap here: eligibility expansions, the use of EPSDT as the basis for comprehensive screening. It calls for comprehensive screening. We should be getting it when we're investing through Medicaid, and Medicaid financing for home visiting, for early intervention, for infant and early childhood mental health and maternal depression, and for enhanced prenatal care and perinatal case management, as well as group prenatal care. I see a lot of opportunities ahead to focus on equity and access and quality, to have states incentivize and finance these kind of high-performing medical homes for young children, to embed effective models within care, and we'll learn more about that with things such as group prenatal care, linking health to the early childhood systems. If we're going to have all the mothers and the babies covered for 1 year postpartum, which I believe we will, how do we support dyadic services? How do we redesign our service systems and pay for that? And then financing an array of perinatal care providers and delivery approaches. Group prenatal care is one, doulas is another. People really are working on an array of effective practices. And we are likely to have more opportunities to have continuous coverage, both in that first year postpartum, but as well for children across these early years and older children as well. How do we effectively maximize that notion of continuous coverage and think about a longer term approach? So with that, I thank you. I will tell you when the slides are shared. I have a lot of references here, and I will now turn it over back to Matt.
All right. Thanks so much, Kay, and thanks, Cynthia, and everybody for having me here. I'm going to try to do a whirlwind 10 minutes with no slides. Hopefully this is informative, because I really want to try to give people kind of a broader sense of what does the landscape look like with respect to the Medicaid agencies and the Medicaid directors who actually run the program. And, obviously my vantage point is I run the association that represents all 56 of the individuals in every state and territory who runs the Medicaid program. And, I have been working with them or for them for my entire professional career, so more than 25 years, and I still find myself constantly amazed by their passion, their commitment, their pragmatism in dealing with an extremely complicated program that is so meaningful to so many people in this country. So why is it relevant here? It's obvious, as Kay said, Medicaid covers half the births, half the babies, about 40% of all the kids in the country, which is really kind of a staggering number when you think about it for a low-income, means-tested program. But it does a lot more than that, too. Medicaid is also the predominant payer of behavioral health services for the country. It is the nation's long-term care system. And as of right now, we're covering about 1 in 4 Americans, period. So it is a significantly large and complicated program covering an extraordinarily wide range of individuals across all demographic groups, healthcare status, et cetera. And the Medicaid directors pride themselves in administering and running a program that is more than just insurance. And really, it's aspiring to be a program that improves access, improves healthcare outcomes, and improves the healthcare experience for the 80+ million people that the program serves. So I wanted to just put a little bit of this in context of, if you're looking to do, implement a roadmap in your state, I'm just going to talk a little bit about how best to do that, how best to approach these issues, and what kind of language needs to be talked about in order to ensure the best chance of success. And I would frame this in the sense that, Medicaid, like a lot of public policy, is all about trade-offs. It's all about trying to maximize the sweet spot between a bunch of different competing priorities, which can include improved outcomes, but will also include, constraining or containing costs. And a specific dynamic that's challenging in this area is that historically, Medicaid, like a lot of health insurance in this country, is built on a medical model. And so trying to figure out how to provide services, how to do interventions that are not quote unquote medical in nature is certainly not impossible, but it's a challenge, and you got to be thoughtful about how you move the healthcare system forward. Kay had a whole bunch of good stuff in there about the 3 E's in terms of historically what Medicaid will pay for and won't. So I'm glad I don't have to go through those. Those are really, really good. But I think it's important to emphasize the note that there is a concern with our federal counterparts. And I think since Cynthia had a slide in there talking about maximizing Medicaid's value, maximizing Medicaid's role, when you use the phrase maximizing Medicaid to a lot of our federal counterparts, they get scared. They get scared that this is mission creep. They get scared that states are looking to leverage more and more and more federal dollars in ways that might not be easy to track or might not be appropriate. That is an important context to keep in mind. That's what states are always trying to balance. How is this going to come across with the feds? They have to approve this. How do we ensure that this is being done in the right way? And I think the final point that I would say that I think is a bit of a challenge is that, again, historically, the Medicaid program has a really interesting dynamic within state government. And Medicaid, for its 50+ year history, has pretty much grown larger than inflation and certainly larger than state general revenues in every single one of the past 50 years. And it does tend to get viewed somewhat suspiciously by budgeteers, by state legislators, by other officials who say, this program is already big. It's now at least 20% of every state's budget. And as it continues to grow, they're always going to be concerned, is it growing too much? Is that a good thing? So being able to articulate why increased investments in Medicaid are important, and why an increase in Medicaid costs may or may not be a bad thing from their perspective. Again, this is something our folks have to manage. Success here is for you, is to help us manage those dynamics, manage those expectations amongst the folks who actually hold the purse strings or are dictating high-level policy. The good news, though, is that we're really at a precipice. We're at an inflection point where there is very clearly a brand new way of thinking about how Medicaid and how health insurance works, and that the debate around the social determinants, or increasingly we call them the social drivers of health, there's no longer a debate that these are one of the most important things that we can do. And that if you think about housing and food security and safety and trauma and early childhood development, there's no question, no one's debating anymore that these things are critical and vital to improving health outcomes and to improving the health experience. Where we are, though, now is the question of, well, which services, which interventions exactly are the ones that you want to prioritize, and who exactly should be paying for them? Because I think there is clearly a sense of Medicaid's got an enormously important role. No question about that. With the people we serve, we will be taking care of them whether we intervene upstream or not. And so it makes a huge amount of sense for Medicaid to intervene in order to ensure better outcomes. But that can't just end with, well, Medicaid's responsible for everything. So really I tend to call this kind of the stone soup approach, where Medicaid comes to the table and says, here's, we can lead with this, and we can show we've got the stone to throw in that pot of boiling water, but we're going to need other entities, other payers, whether those be federal or different state silos, private, charity, what have you, to come to the table and to bring some carrots and some cabbage and some celery or what have you to throw into that stone soup. This is the dynamic that I think we are all trying to figure out what's the best way to do this. And then I think maybe the final dynamic that I think states are going to be challenged with, and that we're all going to be challenged with, is, as we're thinking about prioritizing which investments to make, you're going to think about, well, which populations are we making investments in? Is it the kids? Is it pregnant women? Is it healthier adults? Is it seniors? Trying to figure out where to make those priorities, but also to think about, are these going to be interventions and services that are going to have a clear financial return on investment? Is a healthier patient, is a healthier individual, which is obviously a public good, we want that, but does it actually bring with it a reduction in healthcare spending? That would be great, but if not, we're going to have to think through, if it's just doing it because it's the right thing to do, but it's going to cost extra money, kind of managing some of those expectations and saying, how do we ensure that this still has the momentum and the inertia to get things done? And so I think my last point that I would leave everyone with is that, you're going to find friends in the state Medicaid agencies who want to get this done. They're extremely passionate about improving health, improving outcomes for kids, for moms, and especially along the lines, and Kay noted this as well, trying to address some of the racial and ethnic disparities that have been long extant in the healthcare system for many, many years. But I think my final takeaway to all of you is to say, view us as an ally, but be prepared to come to us understanding the languages that need to get spoken. We deal with budgets. Budgets are real. We deal with the state legislature. We deal with state budget officers. We deal with all sorts of other state agencies. We deal with stakeholders across the system. We deal with our federal partners. Come with us prepared to help smooth out any road bumps, leap over any hurdles that are going to come, and really work with us to try to ensure that the interventions and the solutions that we're talking about here are meaningful, impactful, and sustainable. So with that, I hope that was a good use of 10 minutes, and thanks for having me.
Hi, and I think I'm Elizabeth Burak with Georgetown. I think I am up next. And wow, I have a lot to react to in my scribbles here. Appreciate the opportunity to be here. For those of you who aren't familiar with the Georgetown Center for Children and Families, we're a policy research center that is dedicated to improving healthcare coverage for children and their families. So excited to be here. I think incredible sort of things to think about from Kay and Matt, who I've known and respected their work for a long time and have learned from both of them over the years. I think both of them said something that I just want to reiterate, which I think we're in an incredibly important time with a window of opportunity for how we think about what the healthcare system needs to look like and how it best serves families and children and families. There is even, I just started working on the early childhood side of Medicaid in the last 5 or 6 years. And even in the last 2 or 3, the awareness among specifically state Medicaid folks and others, and not that they didn't already know, but really understanding early brain development and 2-generation and dyadic care and those kinds of approaches has really just the leadership around this specifically in state Medicaid has really grown. And that's been really exciting to see. And we're going to hear from some of those states today. And the awareness around, what are these social determinants of health? What are the things that make it hard to improve outcomes? And what is the health system's role? I think naturally brings us to a conversation about what do we need to be doing for young children? If we know that early development is different than, as we always say, kids are not little adults. Especially in those first 1,000 days, you've got rapid brain development happen. It is all, especially from a social emotional standpoint, all related to relationships with your adults and your parents and the folks around you. What does that mean for Medicaid's role, and how do we think about what the T treatment and EPSDT means in a prevention context? It's a good time to raise those kinds of conversations, because I think while we have a medical system that we've built, and understandably Medicaid is part of the medical system, if we're rethinking the medical system, I think it's also important to rethink what it means for kids, and specifically what it means for young children. And I think that we're in a great place to do that. And Matt, you mentioned that, we always have to think about cost of trade-offs. Any of us who are working in policy, and especially in Medicaid, given the high profile of its role in state and the federal budget. I also think it's important to note that while it's half of the beneficiaries in Medicaid are kids, it's a really small percentage of cost, especially if you're not talking about kids with special healthcare needs. So I just think that's an important lever here, that we're talking about approaches that have clear value for all populations in the healthcare system, but we need to acknowledge that where in long-term care or for an adult with chronic conditions, we might have to save money in the next year, or even the next quarter, it may not be as simple for kids. And that, if we're looking for value and better outcomes. So I think those are the kind of trade-offs we also have to think about within Medicaid programs. The other window of opportunity here, in addition to how we think about health, is there's clearly, I think, a response to the maternal health crisis that we've seen in new options, potentially requirements to extend postpartum care, a lot of the momnibus that just passed in terms of better investments and supporting new moms and pregnant and postpartum moms. And I think it is an opportunity to elevate the kinds of strategies in the roadmap to what that means for young children. If we're going to be taking a closer look at that 12 months after a birth, then it's imperative for the early childhood experts to get in there and say, this is what this needs to look like for mom with group prenatal and all these different benefits. And this is also what it needs to look like for that baby. There is a 2-generation approach here, and it's important. Both the mom and the baby are in Medicaid ostensibly, and how are we serving them together? And what are the conditions in which they need to get mental health, mental health or dyadic treatment or home visiting? What are the circumstances where that comes in? So I just think it's an important linkage to make, especially at the state level. The second thing I would say is also related to sort of Matt's point. It is Medicaid agencies are your friends, right? and it's important if you're not, if you're in the agency, I hope you are your own friend. But I think it's important, especially for advocates or folks outside the agencies, that we're often thinking about Medicaid officials are essentially, they pay bills, and not to say that we're not all worried about health outcomes, but that's how they're thinking about a program that they have to manage, just like any health insurer would, even as Medicaid has a mission and a belief to go beyond traditional health insurance as we think about it. But I think that there is expertise already in state agencies, among advocates and child health practitioners, that can really help the Medicaid agency staff understand the very things that Matt laid out. What are the trade-offs? What are the payment opportunities? Where's the evidence? And I think that particularly because Medicaid is so complicated and because it is so state specific and sort of what your exact policy strategy is going to be, better you make friends earlier, the better. It's not like you're going to get an eligibility change in the law and you talk, it's a very simple change. It is kind of like, what's the strategy? How do we fit what we want to do into the Medicaid policy matrix, which is not prescriptive. Excuse me. One example of that, and I know the folks who are thinking about early intervention will talk about this, but early intervention services that are under mandate, if you will, by Part C, a lot of those are health services, speech therapies, physical therapies. Those are clearly, I would argue, serve the kinds of health services that EPSDT normally covers. So if there's a child who's enrolled in Medicaid and also in early intervention, how is the state working to make sure that kids are getting those services if they're in early intervention? And I think very fewer states than I would think have really done that look with their data systems, just to see, are we getting the kids who we know have been identified with delays, beyond prevention. I think the other thing about working directly with Medicaid agency staff, and increasingly we've seen states with 2-3 staff dedicated not just to kids, but even young kids, which is exceptional. But I think is this whole notion of, all right, what do we mean by, services that might need a medical necessity, criteria, and what do we mean by prevention? Because I would argue the younger you are, everything is arguably prevention. And so what does it mean if a pediatrician says, if you think you might want some parenting programs that are directly related to helping your child's social emotional development? Some states have said that is an important prevention service we think is going to help down the line. So, I think having those conversations is helpful. And then my third sort of bucket, I would say, that a lot of these conversations remind me of is, Matt and I worked at the National Governors Association, at least I did, about 20 years ago together. And my boss at the time there said, we really need to be thinking in terms of policy, not programs. And I think that's especially true in context of the things we want to fund in the early childhood space. And what I mean by that is, we all have models and things that would be important strategies for families. I like that the roadmap says strategies. And for me, it's about how does that fit into Medicaid policy landscape? It might be we have, it's a service that fits into a particular service category, like Family Connects and case management. To me makes a lot of sense. It's a systems conversation that might be tied to what are the best practices in a particular program that we know needs to happen, but not necessarily driven by a model, which is not to say policies aren't attached to models in states, but I do think for the broader conversation, it's just really important to think about the policy implications. And I think it helps to think through how to make sure that a particular service or intervention is accessible, because every community is going to have to decide, what is the right approach for my community. And so the more broad we can say this is a team-based approach, or what are the principles that we can see across these different approaches that we can bake into Medicaid policy or into payment policy, I think that just offers a more sustainable opportunity and to really get more folks in the mix. So thank you for the opportunity to be here, and I'm just really excited about the opportunity to learn.
Well, thank you so much to those first panelists. I really appreciate it. We're going to switch now to folks who have a lot of expertise in actually leveraging Medicaid within their states. And we're going to be joined first by Kate Russell, who's the Medicaid program manager in New York. So thank you, Kate.
Hi, thank you for having me. And like they had mentioned, my name is Kate Russell. I'm the Medicaid program manager in New York State's Department of Health, the Office of Health Insurance Programs. Let's see if I can advance my slide. There we go. There we go. So as a focus for Medicaid redesign in New York, the first 1,000 days initiative recognizes that the child's first 3 years of life is crucial to their overall childhood development. And the first 1,000 days essentially is really aiming to improve the physical, social, and emotional needs of these children, as well as the parents and the families, in effort to enhance their school readiness, their overall health and well-being, by aiming to reduce barriers, increasing access to appropriate community-based services, quality healthcare, education, support systems, to essentially maximize their outcomes and deliver the results to children and their families across the state. Under these pilot projects, the state will work on ways to incorporate the focus of social determinants of health screening and integrate these services into primary care and/or link primary care services to community-based organizations, and exploring the data connectivity options used across the state and determine how or if Medicaid dollars can be used to sustain this work or similar work focusing on maternal and child health outcomes. So the Maternal Infant Care Initiative, and what we like to call as our MICI, is an opportunity for regions to leverage some of their existing work and infrastructure in supporting maternal and child health outcomes. We are piloting different ways of doing this work across all of the regions that are participating in the pilot, by embedding providers in the practice or by establishing contracts between health systems and community-based organizations that essentially already are doing this work. And really by exploring the variety of different providers and how they can support this work. As you can see from this diagram, we're really putting family and the children at the center. And the outer circles are really representing the support of the pilots in conducting the social determinants of health screening and linking families to appropriate community resources by way of the practices themselves, by embedding community health workers / what we call as peer family navigators, as well as a licensed mental health or behavioral health provider, the community itself, and the additional CBOs, as well as the managed care organizations to help support these children and these families to get services. And again, here is just more a little bit about that. The goal of the MICI is really improving access for the high-risk populations, coordinating healthcare, and expanding the universal, what we're calling for the purpose of this pilot, the universal light touch. So the universal light touch for the purpose of this pilot is a modification of the more popularly known, the Family Connects model. And where the universal light touch for the pilot is allowing the peer family navigator and or the community health worker to conduct the home visit itself and screen the child and or family for longer term needs and refer that individual for the more appropriate home visiting type of referral that would be in the community. So here, the goal of the pilot is to use the Peer Family Navigator as a reflection of the community and to help destigmatize the acceptance of services, as well as the support of a licensed mental health or licensed mental health provider in pediatrics, but also in obstetrical settings, to really function as a central intake that assists families that are identified as high risk, high need, either the Medicaid mothers or children that are aged 0 to 3. And like I mentioned, we are incorporating the universal light touch to be provided by these providers versus the traditional Family Connects. And we're not setting eligibility requirements when the intervention can be offered, for an example, such as the first trimester. The pilot is really aiming to explore how each region offers their referrals, tracks those referrals. Do they use a local data system or a homegrown system to report on the follow-up needs? And is that follow-up information being reported back to the primary care or the referring provider, with the goal of increasing referrals to the appropriate home visitation or community-based organization? So here is the slide that talks a little about how the regions are identified and how they differ. As I mentioned earlier, 2 regions are embedding services into their practices, and 2 have partnered with local community-based organizations to have their community health workers to screen their patients for mental health, social determinants of health, and home visitation needs. All pilot providers are required to track and report on all patient encounters, being provided by the Peer Family Navigator itself and or the licensed provider. And we're really looking at specific measures, including the number of families who received support by a Peer Family Navigator, the number of community-based referrals such as WIC or housing, mental or behavioral health, the number of eligible infant or children and or mothers that were referred to an evidence-based or evidence-informed home visitation program, the number of families who received, whose provider received that feedback loop, that closed loop referrals, what we like to call it, and the number of patients who received a light touch. Sorry, I'll go back. Since these are still pilots, the lump sum funding was all straight directed funding, has been sent out through managed care organizations to establish contracts with the community-based organizations or update their existing contract with the participating managed care, practices that are participating. And the goal here is really to bridge the gap between managed care organizations and CBOs and entering into contracts, but also supporting the practice's choice to either hire and maintain the staffing or allow for outside organizations to come and support them in this work. And that's my slides. Thank you.
Hi, my name is Melody Baker. I have the privilege of working with Kate Russell as New York State Department of Health as the leadership on this amazing project. It has truly been a journey. I know I don't have much time, so I will go as quickly as possible. I had some slides, but I'll forego those. But just to give you an overview of my role and what this comprehensive approach looks like. So what I do is I actually provide collective impact training. I provide support, technical assistance for the partners, for CBOs, for the extended community to support the goals of the first 1,000 days. So my role is to implement collective impact and provide that support to the providers. And it is a comprehensive approach. It is an evidence-based practice based on two studies that I'm sure everyone here is familiar with, the Abecedarian study and the Perry Preschool Project, both of which have historically been able to exceed outcomes for that early childhood 0 to 3 population by providing early investments. This is a partnership, again, led by the New York State Department of Health. And I provide the research and the support for the collective impact piece of the project, and also work very closely with external partners and CBOs. There are a few deliverables from my end. As I mentioned, the collective impact training piece. And then the other piece that's really important is the learning collaborative. What I'll have the opportunity to do is talk to these partners and these CBOs, these organizations that support the work of the providers, to understand what can we do better to strengthen this entire operation. The one thing that we know is that providers cannot do everything alone. And oftentimes, especially medical providers, because they're the highest touch point for all populations of children, whether they're high income or low income, they're typically tasked with more than what is expected of a physician. They have to do referrals, they have to provide support that and fill in the gaps for a lot of these families that they care for. And my role is to leverage existing resources to support the work of the state, ensure that there is sustainability, to ensure that any gaps that may need to be filled, that they are there. Oftentimes we can have partners that look to support the work, and because of poor coordination or maybe not identifying the same measures, it becomes more of a burden than not. So I get the awesome opportunity to work with partners and CBOs to really clearly define what does collective impact look like and how can we strengthen these relationships. So that's all I have, and thank you so much for inviting me.
Hi, I'm Maureen Greer, and I have the pleasure of being the Executive Director of the Part C Coordinators Association. So I'm going to talk real briefly because we can spend a lot more time on it in the breakout room, but I'm going to revalidate what my colleagues Kay and Elizabeth have talked about, that under the umbrella of EPSDT, all of the federally required Part C services are fundable by Medicaid. So there's nothing that under compliance issues related to IDEA regulations that Medicaid, in fact, could not pay for. And in fact, across the 50 states, every Part C service is being funded by Medicaid in at least one state. So you know what that says right there is there is tremendous variability. The other, I think the real challenge that I want to sort of put out there for you is that because of the federal-state partnership that is Medicaid, state Medicaid programs control what they are willing to pay for and how they pay for it. And when we talk about 50 different ways of Part C being implemented, there are 50 different ways that those respective states' Medicaid agency fund those services. One of the things that we really talk about is understanding the political and economic context in each state that can determine how Medicaid gets implemented. And Matt talked about some of those issues. Each program, even though in states our Part C people think that nothing is as important as Part C, in fact, we are competing with a lot of equally deserving programs for that same kind of priority. And so part of the challenge that we have is that we have programs that operate in silos as opposed to a system approach. So as Elizabeth said, instead of talking about programs or systems, what we need to be looking at is comprehensive policies or integrated systems of care that are partially funded by Medicaid as well as other resources. We know also that In some states, Medicaid can be administered by the Part C program at the state level. And in other states, it's the activity is conducted at the local level. And so only 32 states in a recent survey, and we'll talk more about that at the breakout room, could actually provide the actual amount of revenue generated by Medicaid. But what we do know is that if every state could provide all of the Medicaid revenue that was generated on behalf of eligible children, it would be the single largest fund source for Part C. So making Part C work for early intervention is critical to its success. And the bottom line is that the majority of states have not fully leveraged Medicaid as a viable payment source. Part of that is because, as Matt and everyone has said, Medicaid is a very complicated program, as is Part C. And the challenge of it is developing the relationships between Part C programs and the Office of Medicaid within the state. The other hindrance to that is that over 65% of our Part C directors have less than 5 years of experience, with the majority of them having 2 years or less. And when you have that kind of turnover, it's very difficult to develop the kind of relationships that are needed. Why do we think for sure that Medicaid has to be there? Is that on average, the median percentage of children in Part C that are Medicaid enrolled is 51%. And so with 51% of the children in Part C as Medicaid enrolled, it means that Medicaid needs to be a major player in that activity. I'm going to turn it back over.
Hi there. I will now go into sharing my screen. All right. Good afternoon, everyone. I'm going to make this really quick. My name is Karenette Hinckley. I am one of the directors of advocacy and government affairs with the Centering Healthcare Institute. I'm so excited to be presenting really quickly today on growing the centering pregnancy model around group prenatal care more broadly through enhanced payment policy. As you can see here on the map, statewide programs already exist for enhanced payment for centering and group prenatal care more broadly in South Carolina, Montana, Texas, and New Jersey. And I'm excited to announce that beginning in January of 2022, Ohio and Maryland will be joining that list. As you can also see here, Georgia and New York have limited pilots with some or all MCOs participating. And then we have at least one MCO offering an enhanced payment for centering pregnancy in Indiana, Louisiana, Michigan, California, and Utah. So what does an enhanced payment for centering pregnancy look like, or group prenatal care more broadly look like? I've seen it range anywhere from $7 to $100 per patient per visit. What we've done at CHI is put together sort of a model policy to find sort of the right size carrot to incentivize providers to use this model that we know is evidence-based, it's incredibly effective, and really to achieve those equitable birth outcomes that we want for all birthing people and all babies. So the model looks like this. It's $45 per patient per visit, and that is for 10 visits. That 10th visit is typically that postpartum care visit. We liked what Blue Cross Blue Shield of South Carolina has done. So they did a retention payment. So we've included this as sort of part of the broader model policy. So it's a $250 provider retention payment, which would be paid to the provider on a one-time basis after the completion of 5 centering visits. And again, that's a one-time payment per patient per pregnancy. So this really creates an overall enhanced maternity bundle of $700 per patient per pregnancy. So for a cohort of 12, that's $8,400 to the provider. And if a practice does, say, 3 cohorts per year, that's an additional $25,200. There are a lot of state policy efforts currently underway to achieve enhanced payment for centering pregnancy and for group prenatal care. What I've included here is a screenshot from the Mama Plus Health Policy Agenda, or the New Orleans Momnibus. And you can see recommendation number 7 here with the arrow reads increasing payment for group prenatal care. So what Birthmark Doula Collective, the Institute of Women and Ethnic Studies, and the National Birth Equity Collaborative have done here for New Orleans is what we at CHI hope that will become a blueprint and actively inform maternal health related policy endeavors of organizations and stakeholders like many of you on today across the country to incorporate into their policy plans and strategies. States can further recognize group prenatal care as a best practice and include this in their maternal health strategic plans. I've seen it in perinatal health strategic plans like in North Carolina, excuse me. And then also in maternal substance use prevention strategic plans. In addition to working with commercial payers and Medicaid agencies, some states will look and have looked to legislation to create this enhanced payment. So one example of successful legislation was in 2019 in New Jersey, where they used legislation to create such an enhanced payment. So what I have here is our amazing dedicated policy team that is here to assist you with achieving enhanced payment for centering pregnancy at the federal and state level. So as you can see, my colleague Mia Robbins, she oversees our policy shop and also manages our federal portfolio of work. And then Brianne Westmore and I split state policy with Brianne on the west and myself on the east. So we'd love the opportunity to further inform and engage key stakeholders and network with you to achieve enhanced payment. So please reach out. I have our email up here. And then I also very much look forward to speaking with you in the breakout session. Thanks.
Well, thank you, Kara, and to all of the panelists. I so appreciate learning from each of you. And I know there was so much information shared, but we wanted to have these multiple perspectives and to whet folks' appetites a little bit to be able to understand what's possible. And now we want to provide the opportunity for you to be able to learn more. And so in the chat, you have information on the various breakout sessions. I'm just going to put them up here so you can see who will be in each of the breakout rooms. And it won't be a webinar, it will be Brady Bunch style so that you'll all be able to see each other. And we wanted to bring to you both national experts and folks who have been doing this on the ground so that you can ask your specific questions, because at the end of the day, we want you to feel like you're able to go back to your state and make happen whatever it is that you think is so important. So there are 3 different breakout rooms. One is the comprehensive screening and connection programs, as well as the evidence-based on visiting programs. And they usually use a similar sort of mechanism in Medicaid to support those programs, which is why we have combined those. And the other breakout session is for early intervention services, or Part C. And then the other breakout session is on group prenatal care. And we now welcome you to, in the chat that you see, to click on the link of the session that you want to go to. It will ask you if you want to leave this session. You say yes, and it will take you right to the other. And so we'll have about a half hour for folks to be able to speak with these experts and each other across states. So again, thank you so much for joining this larger part of the panel, and please go into a breakout session and get the information that you will find most useful for you. Thank you so much.